All right, I'm getting started. This is somebody I want to do a really perfect job on. He's got a complex problem. We're doing a focal treatment. Most people would do the big whack, T10 of the pelvis. And he comes down all the way from Napa Valley from one of the most amazing pain doctors I've ever met. So I have to do a good job. And the first part is getting really, really clean. This makes me feel so good. If I don't do surgery for too long, like on vacation, I feel kind of dirty because something about just scrubbing yourself totally clean is cathartic. Unfortunately, my hands are a wreck because they get so dry, but it's worth it because infections are caca-poo-poo, and one of the most awesome things about minimally invasive surgery, among many other things, is that the infection rate is practically zero because you have much less collateral soft tissue damage and you don't create a huge pocket of blood in a big empty cavity. Good morning, Dr. Choll here from sunny San Diego, California. We have a very interesting, awesome, challenging case. This is a 73-year-old who is very young, patent trial attorney from Napa Valley. He comes from one of the most awesome pain doctors I've ever met, so I have to do a really good job. And I don't know if you can already see the challenge that we have. He has back pain radiating down the right leg. He also has a significant scoliosis. Look at this. So the treatment options for this are pretty scary. One option is to do a T10 to the sacrum or pelvis to get everything totally straight. But his awesome pain doctors identified his main pain coming from the right L5-S1 and maybe the 4-5. But mostly the right L5-S1. So I have recommended a focal treatment because a T10 of the pelvis is like an expedition to K2, whereas what I'm going to do at 4-5 and 5-1 is more like Mount Everest. Still difficult, but very achievable. I don't know if you know, but K2 is one of the most difficult, dangerous mountains, and I consider a T10 of the pelvis surgery an expedition to K2. We just need to make sure that we don't make things worse by focusing on just those two levels. He's in really good shape, so we'll be able to manage these other levels hopefully by keeping him really healthy and fit. Look at that at 5-1. That's the L5 nerve root. That's the nerve root that the pain physician identified as the main pain generator. So we're going to do what I call a focal treatment of scoliosis, and on top of that we're going to use all the latest, greatest minimally invasive techniques so that we can minimize the trauma of the surgery, and most importantly, maintain the integrity of the paraspinal muscles, especially the multifidus muscle, because if we can keep that functioning above the level of the fusion, it will maintain its dynamic stability, and that's how we'll control adjacent level degeneration. Because it turns out if you don't injure the multifidus muscle and detach it from the tendon of the spinous process, the rate of adjacent level degeneration seems to be much lower. So we need to do a perfect job so that he can get back to his lifestyle, because he's not able to do a lot of things that he enjoys doing, including golf, as well as swimming and hiking and just being a captain of industry, because he's the founder of his law firm. So everyone expects him to be tough and warrior-like. He's already had previous hemilaminectomy surgeries to try to do a decompression, but the vertical stenosis is just too much. We need to elevate that and stabilize it, and that's why we need to do a fusion. So we'll utilize computer-assisted navigation, the latest, greatest, state-of-the-art implants, including SABLE, the sexiest cage alive, delicate Asian fingers, and the force, Luke, the force. All right, we're getting started. I have the navigation tracking pin in. Your bone is really strong. That's a good sign. That's your previous incision, and now I want to find the perfect entry point. I still feel like I'm a cheater doing it like this. Look at this. I have the midline, and I have it right down the pike at L4. That's the bullseye for 4-5. And then right down the pike at 5-1. And that's one of the ways you can make the incision smaller and have less collateral damage, by knowing exactly where the center of your surgical corridor is. Woo, this is a big facet joint. That makes sense. I'm really glad it's not locked and fused, because that would make the realignment much more difficult. Once I do the burring and the drilling, I put in a rotating shaver and make sure it's open and clear And sometimes it'll crack loose. I'm sure you're going, oh, that's disgusting. But it's these little steps that make a huge difference. Oh, that feels good. So this is the bone graft we were talking about. It's called iFactor, FDA approved, one of only 2 bone grafts that actually went through an FDA approval process. It's injectable, that's what's awesome. And it has very little inflammatory side effects compared to the other FDA approved bone graft, which is also awesome, called BMP. BMP is not injectable though. So normally, the way I learned and the way I was teaching it for a long time is to use a jam-sheeting needle, which is like a thick needle, I guess, that's kind of bends. And look how tight the pelvis is. For me to torque on it, it would bend and give me all kinds of crazy information. And the entry point, if it was on a slant, would often skyve off. But with this is the way we do it open. I can create the perfect entry point. And then when I use the Sand Eagle hole widener, which is stiff and pointed, I can guide it right down the perfect trajectory. And I want to try to go by cortical. So that is a 45 length. I'll probably put in a 50 screw here. That is a narrow window because of the pelvis and the spinal canal. You can really see how important it is to get a perfect trajectory because that is the pedicle, that little tube of bone. So here's an example of trying to go down a slope. So putting the jam-sheeting needle right there will just keep sliding laterally. And that's how I think I got a lot of screws too lateral when I used to use jam-sheeting needles. Here, I can perch it exactly where I want it. It's cheating, that's all there is to it. We need a better name for it, but right now this is called the San Diego hole widener. I'm creating the tract. It's a triangular or square with sharp edges that allows me to cut into there. And it's stiff enough that I can direct it exactly where I want. And then I can also go tricortical. So I can stop right there, but on deformity cases, I like to poke it out the front cortex where the bone is really strong. We call that a tricortical bite. And look at how perfect I can get it, because in front of that is some scary stuff, because you know what my mom always said, spine surgery would be way easier without blood vessels and nerves, and the common iliac artery and vein, vena cava, and other stuff like the bowel up there. So it helps to have delicate Asian fingers here and being able to read Braille. Ooh, this is scary in a good way. This is L4. It's the smallest pedicle so far. I like that a lot. So this will temporarily kick over because of the pelvis, and then I'll tilt medially to find the hole. Oh, this is going to be such a good bite. Oh, look at that. Can you hold that? I have to go two-handed. Woo! 50 was perfect. Thank you, guys. Wow, that's going to be a good bite. This is the other reason why navigation is so awesome, because this is a tight pedicle, and you want to put it right down the pipe. All right, so I want to find that other hole anteriorly. I think it was right there. Yep. I have all the screws in. They're perfect. I hate to be too boastful, but they are. And now I'm doing the MIST lift part. That is the facetectomy, decompression, and interbody reconstruction infusion. This is the expandable tubular retractor. So the surgical target site's about that big. If you do open surgery, the corridor is usually that big. But with MIS, we try to use it in a parallel corridor. It's just a minimally angulated corridor. So the opening is about that big, target site's about that big. So it's a really shallow funnel. And that minimizes the collateral damage of the surgery. That's my story. I'm sticking to it. It's going really, really well. You have good bone, good tissues. I'm feeling good. Hopefully I'm looking good. And gosh darn it, cats love me. I made a little window in the area called the working triangle, which is the interval between the traversing nerve root and the exiting nerve root. And if you position it exactly right, you don't have to use a retractor to get the nerve out of the way. You just work in that little, I don't know, crotch, if you will, and try to avoid manipulating the nerve root. Okay, I'm doing the discectomy, but more importantly, the end plate prep. I want to remove the cartilage from the surface without injuring the integrity of the bone. And this is where I use delicate Asian fingers and have my pinky out. And this is the part where it tests every surgeon's patience. You just want to go in there, just rip out all this disc material. But you want to not be mean to the end plate. Oh, this is feeling good. No melon balling, just parallel scraping. Wax on, wax off. All right, T, here's the second place I put in the bone graft. This is the most important spot. In the inner body space, and remember we're talking about it? It's injectable. I don't know if you can see how gooey that is, so I'm gonna put it through that little opening, get it right where I want it, mostly on that side. Don't tell the hospital, but it's really, really expensive. But only the best for my patients. The other bone graft that's FDA approved that I like is also really, really expensive. The cheapest is your own bone from your pelvis. But it begs the question, it's cheaper for the hospital, but is it cheap when you take into account everything? I don't know. Not only is it injectable, but it fills in all the nooks and crannies because it's flowable. It intercalates into the tissues and the bones. And I like that too. And just surrounds the cage. Printed surfaces where the design has a bulleted nose, soft edges. It is 12 millimeters wide and has a huge graft window. And once I take this little pledget out, I can backfill it and it will expand like you would not believe. You'll see that on the x-ray, but the expansion profile is tremendous. This is a very scary part of the surgery where I have to put this graft on a little narrow window, and I made all kinds of crazy care to keep the bony edges so that it acts like a block and protect the nerve. And then Dr. Asimov is telling me if anything bad happens. How's that, Dr. Asimov? Quite as good here. All right, here's the part that I call, well, I call it the inner body erection, but I feel guilty every time I say that because it's so crude, but that is the best description of it. Look at that. Not only is it just beautifully lordotic, the expansion is just tremendous. I think this implant has one of the largest expansion profiles in addition to the lordosis. And hence, it's called the sexiest cage alive in my book. And I have that little technique called the shuffle, going back and forth. Because without that, it's too hard to tell. This is the important part too that we're talking about. Once the cage is expanded, there's a big hole in the middle of the cage. So most of the bone grafts are around the cage. It's also titanium. But this implant you can backfill because you can take the skinny little thing with the injectable bone graft. I know, it's not fair. It really isn't fair. I'm at 5'1". Again, you can see I'm going right down into this space. But more importantly, I'm angling it so that I'm very much to the right because I want to put in the spacer on the right side so I can jack up the right side and untilt it. So having three-dimensional imaging is just awesome. Okay, I'm doing 5'1" now. This is the level where it's all collapsed. I feel like I'm driving on an icy road with my entire family in my car. Zero room for mistakes. Absolutely none. Right, so I've accessed what I call the working triangle. See, I'm at the back of the disc. Look at how narrow the window is that I got to get. Above that is the circle or the oval where the nerve root is. Oh, I feel so good. I feel so lucky. I'm in the space south of the exiting nerve root, right on the disc space, making sure that the nerve is free. Yep, you can tell the nerve knows I'm trying to release it. It's scarred down, but it's not nearly as bad as I thought. Look at that. See how I can go back and forth? Feels so good. And now the S1 traversing nerve root. It's like taking gum out of shag carpet, but really, really expensive shag carpet. Like a priceless antique. Thank you. That's what I fully expect based on my work right here. I am unsticking the nerve from the scar tissue. Traversing, almost completely free. Exiting, free. That was the, I don't know what part of the Mount Everest climb is like the most scary and dangerous, but that was it right there. Yes! I see all the Goomba that we saw in the MRI too. You poor thing. Okay, I'm in the disc space at 5'1". Same thing, gentle, delicate Asian fingers, wax on, wax off. Look at that expansion. It's just, you'd think after so many cases I would just go, Oh, been there, done that. But it's like when your child does something cute. Everyone else thinks it's just lame, but you still think it's unbelievable. Your child is like a genius. This is my child. Oh!
That's good though, right?
Oh, it's so good. I can feel it. Yep, it's perfect. I can't wait to see the final x-rays because this side is elevated up like, I can't wait. It's going to be huge. And then that created the largest opening for the exiting nerve root. The exiting nerve root is just like it was underwater for too long and took a first big breath of air. And then there's a bone spur at the edge of the L5 vertebral body. And the traversing nerve root going across was stuck to it. And I just realized that, so I'm like, I can go back and forth, side to side. Oh, I feel so good. If you don't get better from this, I will eat my hat. Sleeves, it'll guide me down to the top. And then I will put this through the top one, down, and then put nuts down there, and I lock it down, and then I disconnect it. If you're a spine surgeon, you think like, that is genius. If you're a carpenter or like a normal person, like, yeah, we do this stuff like that all the time with all this stuff. Surgery's all done. I am so happy with the results. So this is pre-op. Here's the pelvis. Look how tilted over that is. And then, no. Look at this final result. I can't even believe it. Here's the pelvis like this. Like that. Look at that. It also derotated. I put 2 cages on that side to really jack it up. The 4-5 level just needed to be realigned and derotated. I still put the cage more on the right side. And then there's the lateral. Look how tall that is. Look at the neuroforamen. And this is why this is the sexiest cage alive. It is so perfectly lordotic. It fits so well. It's almost like a custom fit implants. And then finally, even more awesome, it looks a little gross, but the incision's only like about that big. You'll see that with the dressing. Look at how small those incisions are. That's the size of my thumb. That's the navigation tracking pin thing, but it went so well. I can't wait for you to wake up and stand up because you're gonna feel so much taller, stronger, faster. Wait, that's something else, but you know what I'm saying. So get better soon, and if your right leg doesn't feel better, I will eat my hat.